Good morning, everybody. For me, I was lucky in coming to Thailand because for the past 1 week, many of my colleagues in India had rejection of visa for some reason or other. And at the last moment, we had an opportunity of being given the visa, and we came last night. I thank the Global Fertility Academy for asking me to be part of this program, and I try to do the best I can. In this talk, or in this 30 minutes, the scientific material that has been taken is about the various modalities of assessment of the oocytes and of the endometrium and the embryo. The current technology which has been there in the last 2 to 3 years is summarized about their potential benefits and negative aspects. The topics which have been allotted in the paper sessions are: one is the imaging of the time-lapse, culture media and the role of mass spectroscopy, humulus cell gene expression, S100 protein, GMS CSF, and a thin endometrium. What you should look at is, in that thing is, half to 3/4 of the topic are about genomic medicine. And as gynecologists, we should wake up and move ahead in understanding genomic medicine. Genomic medicine has come into our doorsteps, and unless we understand the intricacies of genomic medicine, we end up looking at data which may or may not make good quality science for us. In the first topic, which was presented by Cohen, he was speaking about the embryos with good morphology, with abnormal cell division, have significantly lower implantation potential. In this thing about the time-lapse imaging, there are 2 papers. Both of the papers, the main context that were given is, why is time-lapse imaging important? What's the information it gives to the gynecologist or the clinician who heads the unit? And what's the information it gives to the patient? Many times we are facing a situation during stimulation. The patient asks, how are my eggs? We say they're good or something, depending on the E2 levels in the follicle. And when we go into the oocyte pickup, we have few modalities like this spindle view. And as we go into the fertilization, we just rely on the embryo grading. In this thing, the use of time-lapse microscopy assessment improves the selection of embryos with increasing implantation potential. If this is true, the dream of reducing the multiple pregnancy and selecting a better embryo so that the morbidity that is associated with IVF or ESHRE will be greatly reduced. It's essentially a dark field microscope with multi-well discs and a software which takes the images in multiple directions at fixed intervals and then transfers the images to outside the incubator to a software system where the embryologist can monitor the progress. In other words, this technique has reduced the number of times we open the incubator, and also it also tells us how things are to make a decision if somebody is doing a combination of day 3 or day 5 transfers, when to do the transfer. Here in this slide, they compared 3 embryologists to assess the quality of the embryos, and those embryos which were correlated with the EVA system, and they found a huge difference. In the embryologist 1 and 2, the person who is making a good quality embryo is at least half of that, and the third embryologist is practically coming to a very close efficiency as the EVA. What this tells us is, the current method of assessment of embryo assessment is very subjective, and it differs from embryologist to embryology. Maybe in future, this is one of the parameters that might become standardized so that the variability and assessment or the communication tools that are given from the clinician to the patient or from the embryologist to the clinician will be at least standardized so that all of us speak the same knowledge and the same communication tools. Here, the good morphology embryos which ended in having a good outcome, not all good embryos were picked up by the embryologists, and the EVA has picked up some of the good embryologists. So it says that maybe it has a role, but with more information and a possible meta-analysis and the actual field information about its economics and the reality might make this tool a good tool. One important thing is, if an embryo is said to be suboptimal by EVA, it does not mean it's a genetically abnormal embryo. It will not implant. So this information which we have from the embryo scoring method is mainly useful to help us to understand and to give a right quality embryo, and also to communicate how the status of the embryo. A lot of times after a failure, we come across a patient who says, "Doctor, you said the embryos are good, and we don't have any tools apart from that, and the timing of the cleavage division and the quality of the embryo will help us to subdivide some of these patients into having a more precise information so that it might reduce some of the grief of the patient." The conclusions of this study is, imaging of the human embryos has the potential to eliminate embryos from transfer consideration based on phenotype and cell division timing. Improved embryo selection may increase pregnancy rate following IVF and allow more patients to elect for single embryo transfer. Imaging technology, if and when available, can be easily assimilated into the clinic. The ongoing studies are investigating aneuploidy fragmentation and prospective EVA to assist in embryo selection transfer. This is a similar study, but taking a different parameter in terms of kinetics of cell division, where the current embryology group are trying to produce a classification which might help us to implement in the laboratory system. The basic concept is there is a difference in timing of chromosomally normal and abnormal embryos in cell division, and morphokinetics can probably increase the selection of those embryos. In this parameter, many parameters are considered. One is the age, the etiology, the stimulation protocol, the pH of the media, and the temperature, and also the etiology for which the procedure is being done. In addition to that, you have the timing of the cell division and the embryo thing. In this study, all the people who had the biopsies had on the third day, and then looked at the people who received the embryos on the fifth day. Here is the model wherein they divided the groups into a time-lapse imaging which had a kinetic morphology and dynamics, and then a PN scoring and a triploid embryo by the pre-implantation genetics diagnostic screening, which helped to produce an algorithm of selecting the best blastocysts. In other words, when you're looking at kinetics, you have the input of the technology where it gives the kinetics and the morphology of the embryo. Then you have a tool which we are using it to cross-check whether it's right or not by doing a PGS. And then an algorithm is based on that to see whether a prediction can be made so that the number of aneuploid embryos we might transfer without knowledge can be decreased. This partially tells us the percentage of normal embryos according to the classification. The conclusions were significant difference between the normal and abnormal embryos were observed for the mean average of the following variabilities, that is the T5, CC2. Embryos falling into the optimal range for the variabilities, that is the T5 and CC3, were significantly more likely to be normal. Each category showed difference in the proportion of normal embryos. The algorithm may offer a new selection tool for embryos when genetic screening is not available. One of the limitations of this statement is it does not pick up mosaicism. In the next group of papers, the emphasis was on moving to microRNAs. MicroRNAs are increasingly being used in assisted reproduction. That means we have come from a basic chromosome, a gene, a polymorphism, where you saw in the previous lecture about the 680 polymorphism in FSH receptors, and then you are moving into the RNA, and finally, maybe a decade later, into the proteomics in reality. In this expression form, where a microarray was used to check the type of expression the cumulus cells have and the oocytes have, so that the oocytes which have a better potential can be used. For example, in Italy, where only 3 oocytes are used for the procedure, this procedure might be useful for them to use it as a tool. The transcription profile of human mature oocytes in the surrounding cumulus has been identified, and very little is known about the post-transcription microRNA regulators, and this study was trying to identify some of those parameters. In this, the human cumulus cells and the follicular fluid were taken. A deep sequencer called the Illumina was used to sequence the pattern of expression, and these gene expression profiles were then read and then tabulated according to the data that was available worldwide. The key results of this work was high throughput sequencing identified small RNAs of 19 nucleotides in cumulus cells and of 19 and 25 nucleotides in the M2 oocytes. In other words, a pattern is being formed to find out the quality of oocytes in using the technology of microRNA. When you're looking at the oocyte, in the beginning years, it was the surrounding cumulus cells. Later age, the cytoplasm and the nucleus findings. Subsequently, the spindle imaging has come, and now you are having an expression of the RNA studies which will reflect the quality of the oocyte. These are all tools to help us to understand the basic concept and also go into this field to provide a better information to all of us and to the patient. The carry-home message in this mRNA study is it's an evolving technology which is helping us to understand it, and the information that is present at this moment is quite low, and it gives an opportunity for many people to move into this direction and understand the genomics and also look into the microRNA for having a prospect of good career in the area of academics. The key points in this lecture are predicted target genes of the oocyte microRNA are associated with regulation of transcription and cell cycle, whereas predicted target genes of the cumulus microRNA are involved with the extracellular matrix and apoptosis. So the two types of information you're getting is about the cell cytoskeleton and the oocyte competency. When you looked at the previous slide where the previous speaker was speaking about the 680 polymorphism of FSH, a single polymorphism of a particular group of problems may not yield good quality information, because when you look at this slide, the number of genes that are involved in the regulation of the follicular development and maturity are large in number, and we are just unraveling those implications so that it helps us to understand better. Genes that are differently expressed in oocyte and cumulus are predicted targets of oocyte and microRNA, which will help us to plan the stimulation protocols or the addition of luteinizing hormone in the time to come. The conclusions of these cells are high throughput sequencing identified small RNAs of 19 nucleotides in cumulus cells and 19 and 25 nucleotides in M2 oocytes. The predicted target genes of the oocytes are associated with regulation of transcription and cell cycle, whereas predicted target genes of the CC microRNA are involved in extracellular matrix and apoptosis. These findings may play a role in the crosstalk between the oocyte and the cumulus cell, and it might become a future biological biomarker for oocyte health. As you have seen the advent of the microRNA and the time-lapse imaging, another technology which was being a lot of publication work has come in the last 3-4 years or 5 years is they're using the mass spectroscopy to look at the production of metabolites that happen in the culture. And in this study, use of culture media amino acid mass spectroscopy measurement in identifying embryos with the best implantation potential. And the purpose of this study was to answer any association with culture media amino acid turnover as detected by mass spectroscopy and reproductive outcome. In the initial years, they thought pyruvate and glucose has a major role and might become a marker for pickup. Later, they found an association between glycine and leucine, and subsequent time, the asparagine in culture media. The high glucamate level has been shown to correlate with pregnancy and live birth. Standard embryo grading has limited value in predicting outcomes. This study aimed to identify amino acids in culture media that may be used as a biomarker for successful implantation. In this procedure, the authors have found that the day 1 culture media had a higher incidence of serine and proline, which were highly predictive of pregnancy. In other words, you're moving from a marker which is 1 day old, which will help you to plan or discuss with the patient the number of embryos that can be transferred. The key points of this lecture were pregnancy rates were associated with number of day 1 serine or proline selecting zygotes transferred. On day 1, secretion of serine and proline were highly predictive for pregnancy. Pregnancy rate were associated with number of day 1 serine and proline secreting zygotes. These results suggest that the quality and implantation potential of an embryo can be determined immediately after fertilization. Hence, serine and proline levels in fertilization media can be used as a predictive metabolite marker for pregnancy that may surpass current morphological markers. It is one more technology that is available in terms of the time lapse, the culture of the analysis of the culture media, and the microRNA. From oocytes, we are moving into the embryos, then we are moving into the endometrium. This study, it was more a review lecture. It was on the contributions of endometrium to endometrial implantation. And this lecture and the previous first lecture are on the ESHRE website, which will help you to understand the concept in a much clearer way. The website name is ESHRE 13 meeting, and wherein you log into the webcast, where the whole lectures are there. And these lectures are, the first was about the time-lapse imaging, and this lecture will help you to understand the concept and the trends that are happening in this field. In this review, the author was speaking about the presence of endometrial receptivity is dependent on many factors, and the implantation window that happens have revealed that desugilization of endometrium act as a biosensor of embryo quality, and this is mediated by the cytokine response to the presence of poor oocyte quality embryos. Migratory response in the presence of high quality embryos is good. The contribution of the endometrium to embryo implantation, where in this article it was discussed about the cytokine response is reduced in the poor quality embryos. Before it was thought that the embryo makes all the decisions to implant. Now the process is moving away to an endometrium which is inert in a good quality embryo and becomes non-receptive. It's a poor quality endometrium, which was suggested by this study. In the same thing, they also did a study on recurrent pregnancy losses, recurrent pregnancy failure, and the normal implanters. They found that interleukin and the PROK mRNA levels are different in the recurrent pregnancy loss and in the recurrent implantation failure, suggesting that the spectrum of implantation failure and early pregnancy loss may not be the same as we have been thinking for many years. In recurrent pregnancy failure, the decidual phenotype abnormalities may be opposite to those in recurrent miscarriages, which shows our earlier understanding might undergo a change in the coming years. The contribution of the endometrium to the embryo implantation. This information will help to develop novel therapeutic options to correct the defects selectively, allowing good quality embryos to implant when they otherwise might be rejected, and preventing the implantation of poor quality embryos, which might lead to miscarriages. The additional biomarkers that were found in this area are the current biomarkers of the endometrial lining, the embryo grading, the hysteroscopy have not lived up to the full potential, and the understanding of endometrium and the implantation is improving in the past decade. Here we are moving from a basic histology to imaging, then a gene analysis, a protein analysis, and the secretomics. This study was trying to identify whether aspirating the fluid from the endometrium before the embryo transfer will alter the implantation potential of that patient. Aspiration of the endometrial secretions is safe, and in this study they tried to identify the study group and the control group, and the conclusions of the authors were aspirations of the endometrial secretions is safe and does not affect the pregnancy rate. So this study is helping us to understand and open our eyes that we might be able to aspirate the fluid from the endometrium and then use that information to see whether the implantation window is appropriate, and in turn helps us to do or time the embryo transfer in a better way. In this study, the information they were looking at were interleukins and the tumor necrosing factors. And the conclusions were aspiration of endometrial secretions provide an endometrial fingerprinting that can be used as a predictability for embryo morphology and implantation. You have an interesting concept wherein does endometrium choose the embryo? This is the area of information which will change the concept of ectopic in the coming years. Emerging evidence suggests that the endometrium chooses the embryo. Poor quality embryos cause less migration in fertile women, but not women in recurrent miscarriages. In this study, the endometrium and enigma were an obstacle for implantation. The analysis was done with the donor oocytes, and the end point of this lecture is what is the ideal endometrium at which a transfer should be done, and what is the cutoff level at which one should not do a transfer depending on endometrial lining. The combined effect of endometrial thickness with and without other uterine factors on clinical pregnancy and live birth in oocyte donation recipients. What is the effect of increasing estrogen dosage in recipients with endometrium less than 6 millimeters on pregnancy and live birth? All of us go through this question many times in our daily practice. The concept that was taken is, at the moment of the writing of the article, is ideal endometrium is accepted as 7 millimeters. Cycles of endometrium less than 6 millimeters are usually cancelled, and the recipients are treated with higher estrogen. The question that others wanted to answer was, if the endometrium is less than 7 millimeters, are we doing the right thing in cancelling the transfer? They did a retrospective trial on 737 oocyte donors. Ultrasound measures of endometrial thickness and texture. HSC was used to diagnose intrauterine adhesions, and the endometrium is graded according to A, B, and C. The key points of this summary was endometrial thickness between 9.1 and 10 millimeters had a highest clinical pregnancy rate and live birth. However, when intrauterine adhesions have been ruled out or resolved, pregnancy and live birth rates are similar to all endometrial thicknesses. In other words, what the authors were suggesting is, if you have excluded endometrial pathology and the uterine synechiae at a endometrium between 6 or so, the probability of transferring is giving a good pregnancy rate. In one of the surveys of worldwide fertility, IVF worldwide, where they analyzed the oocyte donation patterns and the acceptable endometrium at which they were transferring, there were people who were doing transfer at 5 millimeters, there were people who were doing transfer at 10 millimeters, but most of the people who fall in the 50th percentile are between 7 and 9 millimeters of endometrium. What it says is, you have a wide spectrum where it can be done, but the best things occur at the mid-range. The conclusions of this study were endometrial thickness between 9 and 10 millimeters results in significant higher pregnancy rate. When intrauterine adhesions have been ruled out, pregnancy and live birth are similar. Thin endometrium in the absence of intrauterine adhesions should not be the sole reason for embryo transfer cancellation. A new biomarker is coming in the area of endometrium called S100 protein. Apart from the existing endometrial markers, this new marker has been selected for investigation by this group, and they found that this marker's presence varies in different phases of luteal phase. In the early luteal phase, in the mid luteal phase, and in the late luteal phase, the concentration of the S100 protein varied. The biomarker is expressed in stromal and epithelial cells and overexpression in the endometrial cells during the embryo implantation window. The conclusions of this study were the new S100 biomarker is expressed both in endometrial and stromal cells. Protein knockdown was achieved by RNA. The biomarker may play an important role in future as we understand the role of S100 protein. Further studies are going in to understand the effect of depletion of the biomarker on the process involved in endometrial receptivity. And at this moment, an overexpression of the biomarker role is currently unknown. When it comes to the freezing of embryos, whether it's the vitrification or the slow freezing, more information is coming that the available information does not say that we are completely eliminated or found out that vitrification or slow freezing is absolutely safe. In this study, the authors were trying to analyze the protein expression studies of the cumulus cell and the oocytes and found, depending on the type of freezing protocol, the microRNA expressions were varying, and the procedure, whether it's vitrification or slow freezing, has different responses at different cell stages. A day will come when, in using this information, we might find an ideal time to do the vitrification so that it produces less negative effects on the offspring in the coming decades to come. These genes that were upregulated and downregulated, the key summary of this study was several highly significant gene alterations occurred in vitrified and slow freezing rates, which puts to rest that we do not have complete information in terms of saying the embryo freezing or the vitrification protocols are absolutely safe. Just because we don't have information, it does not mean they're 100% safe. The conclusions of this group were several highly significant gene alterations occurred in vitrified and slow oocytes. Change in gene expressions due to oocyte cryopreservation may have long-lasting biological repercussions. Further research is required to confirm these changes. The choice of oocyte cryopreservation method may be influenced by these findings. The findings also guide further optimization of the cryopreservation protocols. In the last study, the granulocyte colony stimulating factor treatment in implantation factor using a fixed dose of 60 micrograms per day, a preliminary data of a controlled trial. In this, they have used 60 micrograms of granulosa colony stimulating factor on alternate day from the day of embryo transfer, and we are looking at the results in the implantation failure group. The GCSF is a cytokine that promotes leukocyte growth and also the trophoblastic development, and it has been shown that granulosa colony stimulating factor may be useful in the treatment of recurrent abortions. In this study, they have taken IVF people who have 3 IVF failures with good quality embryos, and they were randomized into 2 groups, one group receiving the granulosa colony stimulating factor and the other was receiving the saline, and they compared the primary outcome of pregnancies. The pregnancies and implantation rates as well as beta HCG levels were significantly improved in the colony stimulating factor group versus placebo. In conclusion, pregnancy and implantation rates as well as beta HCG levels were significantly improved in the colony-stimulating group. The preliminary data in these 50 patients suggests treatment with colony-stimulating factor may be a beneficial treatment of women with recurrent implantation failure. As every study, they say definite conclusions are not possible due to the size of the study, and further studies are required.
Okay, we thank Ramaraju, a very nice presentation regarding implantation. I think the implantation is really a very difficult enigma. It's like blind to the stem elephants. So I think this year we have probably a lot of tool and technology try to figure out this implantation potential and the window implantations, like omics, but none of these have a very solid result to answer such kind of question regarding. So any comment or question are very welcome for this. Yeah. Yes, please introduce yourself.
I'm Shweta from India. Regarding the last talk regarding GM-CSF, I was wondering that when you went through their study, were they monitoring the white blood cell count when they were giving a daily dose of GM-CSF? Because I think probably that bothers us when patients are on GM-CSF.
One thing that should be realized in this study is it's a pilot study, yes, and trying to say a proof of concept. And in this, they monitored the counts, but they have not given the complete details of the counts. Okay. And when I went into the other data of GCSF, I found that this is a tool, but we can look at the data that's available in the other areas of medicine, and look at the adverse reactions when it's used for long term. And then, as and when, or one of you can do a trial to find out those answers. But this is providing an information saying, here is a tool that might help us for future.
And one more just question, that do you have any personal experience regarding endometrial scratch? Of course, this is beyond this presentation, in improving the implantation. Have you tried that in your center?
We have been doing a diagnostic hysteroscopy one day before the stimulation protocol for many years, and we didn't find any negative effects. But regarding the positive effects, I don't know the answer.
Okay. Thank you very much.
Any comments? Yeah, please.
Thank you for the nice presentation. I am Jun from South Korea. I want to ask about the microRNA. You presented MIR184 is abundant from the oocyte. I want to know that did they study the relationship of concentration of MIR184 and the oocyte qualities?
Honestly, in the area of microRNA, my knowledge is not apt. But when it comes to the receptor of FSH and LH, if there are any doubts, I can clarify with certainty.
Great. Any comments or questions? Even now, so we will thank Professor Gottumukkala again for your presentation.